together and for having me speak. So I don't need to belabor the first few slides in light of time, but we've been fortunate to be able to increase survivorship of brain tumor patients because of fabulous work of neurosurgeons, high-dose chemotherapies, cranial radiation, including stereotactic and proton. Most can lead to various late effects. We also, Dr. Maverick discussed earlier, the physical changes, a variety of reasons, white matter changes specifically, disrupting the role in promoting efficient transmission, reduction in normal appearing white matter, which is positively correlated with IQ, so less normal appearing white matter, lower IQ, damage to blood vessels, focal areas of calcification. I wanted to put this in as well to give you a sense of prognostic variables. So there is no safe age at radiation. Every study that looks at younger versus older, no matter what the cut score, 4, 6, 8, is always significant. There is no safe age, as I mentioned, but clearly younger is worse. Kids who are in their early teens, maybe less harmful. Higher dose, clearly, risk factor, and larger volume, obviously a risk factor. Longer time since radiation, I think that's been shown now. It's length of time. People don't come out of radiotherapy less smart. They may be tired and somnolent and fatigued and don't do well right away. But I like this next slide. Specifically, I always try to put it in because the whole idea is that just to stay at a mean IQ of 100 for a normal, healthy person, as they get older, they have to learn more information just to tread water and stay in the same place. Kids who have been treated with craniospinal radiation plus a boost for medulloblastoma will learn, it's positively sloped, but it's around 65 to 75% of the rate of their peers, so they're falling further behind as you get away from time. So the whole point of early intervention, early identification of problems, and remediation here to close the gap as opposed to waiting here is really integral. Core deficits are a few. Sustained attention concentration. It's not as if kids can't pay attention, it's that they focus in, they focus out, much like you guys are doing in the audience today, I'm sure. Fine motor processing speed, again, not just for writing as we test them, but processing speed for thinking, reading, coming up with answers, generating responses. It's a response speed for everything. And fine motor dexterity, clearly with the cerebellar tumor. So because of that, the IQ goes down, but it's really specifically processing speed and working memory, which are 2 out of the 4 indices that bring down the IQ. Academic achievement, particularly not exclusively, but mathematics as a right hemispheric task. Again, right hemispheric visual learning and memory, visual motor functioning, perhaps because there's more white matter in the right hemisphere, executive functioning difficulties. I just want to also be clear, the role of gender has been touted in some publications as a risk factor. It has been documented clearly with ALL, kids who get intrathecal methotrexate, for lowered IQ and verbal memory. But this disparity has not been widely demonstrated. It may be, we need to be mindful of it, but one particular study in particular was Doug Reese, here we go, up here, that he was basically saying that female gender was a risk factor. However, in the study they used modeling to predict the IQ scores, and there's a disproportionate number of males and females, so we just need to be mindful of jumping to conclusions and repeating things we see in the text. Female patients do, however, report lower physical quality of life and endorse more depressive symptoms than males. So for example, early identification would be for physical therapy and therapy support for females. High baseline I thought was interesting just to throw in here briefly is that 3 studies, Children's Cancer Group, COG, and St. Jude's, have all documented those who have higher full-scale IQ or baseline processing speed, working memory, and attention display higher rates of decline. I think it's important to be mindful, though, that they still, even though it's a steeper slope, they start out and wind up higher than those who have a flatter curve who started out lower. And then just parenthetically, just keep in mind that that same group of high IQ kids are the ones who generally do better with computerized interventions, pharmacologic studies. And the idea of, actually, I just want to mention that the whole cognitive reserve theory of those who have higher IQs maybe could withstand insults better. This runs counter to that. The other theory of regression to the mean could also be pulling their scores down to the average range. Anyway, I wanted to get on to the study at hand. Head Start 2 has been a study I've been involved with since its inception. 49 out of 51 patients were evaluated 2.9 years of age on average. They were treated for malignant brain tumors, and they underwent baseline neuropsych assessment prior to autologous hematopoietic cell transplantation. A prior publication from 2010 showed that based on 26 survivors, as 20 had passed away, documented full-scale verbal performance IQs to be stable over 3 years. So the question was, we need to continue to follow up to see if actually does it continue after 3 years or not. So most recent data, which I'm presenting today, is from 27 survivors after a mean follow-up of 7.39 years. That's roughly 4 years later than the prior publication. Their mean age is roughly 10 years of age. I wanted to do two things, really describe the most recent follow-up compared with age-based norms, and also compare them with their baseline assessments. So just to look at this, basically we talked about 7.39 years. They're 10.41 years of age, 70% mental OP&ET. Regimen A was 48%. Regimen A2 is interesting. It was 5 cycles if you had disseminated disease of 12 grams per meter squared of intravenous methotrexate. Radiation therapy, I think this is critical to appreciate. You have roughly 2/3 who never got irradiated, and a third who did get irradiated. The theory is to avoid or delay radiotherapy, and of those who did get radiotherapy, on average, you see it's 5.41 years. The average age of diagnosis is 2.9, so you're basically getting a few years of delay on average. Sorry about that. So I wanted to just show you in the last minute or two a couple of pieces of information. One I mentioned to you at the most recent follow-up compared to their age peers. So you're looking at full-scale IQ being low average. Basically, you want to appreciate, yes, the range. So there are low kids, but there's also very smart kids in the cohort. And mean is 100 for this test with a standard deviation of 15. So you're looking at standard deviations that are a little bit larger than 1. Low average verbal comprehension, perceptual reasoning, working memory processing speed, again, average to low average. Reading, spelling, and math, basically within the average range. Receptive language, low average. Visual motor integration, average. And then memory, I think, is really critical, again, within the average range. And then social emotional within normal limits. Just a few last things. We looked at change over time, either case matched, which is did they have prior testing, and we followed it up. Their full-scale IQ declined 0.27 points on average. We looked at pooled data, everybody at baseline, everyone at most recent follow-up. Again, IQ, full-scale declined 0.09 points, verbal IQ declining 2.52, and performance improving 0.73, so quite a stable profile. I just want to blow through some quick slides for 1 minute. So there were no significant differences, the take-home message, on average. And in this study, no significance is a good thing, a positive thing, because we don't want to see decline. But so having said there's no significance, I just wanted to throw up a few slides. This basically shows what I mentioned to you with 2-point axis. So if you looked at mental OP&ET versus other, you see the other, which is ependymoma, ATRT, Astro, GBM, 30% of the population. Did a little bit worse, but again, not significant. Tumor location, infratentorial patients doing better than supratentorial. Younger kids, less than 26 months, doing better. That may be a random finding, again, not significant, but also may be that the younger kids were avoided radiotherapy. Here, again, not significant, but female gender did start to go down, so I remain cautious. Female gender could be a risk factor. It's not borne out in this data yet, but it's important to be mindful of. The last piece I want to leave you with is, yes, you're trading off radiotherapy for high-dose intravenous methotrexate, but I wanted to tell you that looking at methotrexate kids and no methotrexate, doing worse if you've got methotrexate, and then specifically processing speed, methotrexate group is at 81 on average, no methotrexate, 10 points higher at 7 years out. Working memory, same thing, 83 methotrexate, no methotrexate, 97. And I think these are important because then Head Start 3 about half the group had 3 cycles of 12 grams per meter squared. There's a change in the balance of the last 50% got 3 cycles of 8 grams per meter squared. So it's something that's important. It's not to say it's innocuous, and it's important to be mindful of. So summary, just to be mindful of time, pretty flat IQ, as opposed to the loss of 2 IQ points a year that we see with other traditional craniospinal plus radiation boost. Although not significant, mentioned low PNET tumor type, infratentorial males, younger age, and non-exposure to intravenous high-dose methotrexate demonstrated a higher mean overall IQ. Group is within the average to low average range. And the last slide, promise, because I'm running over and I want to be mindful, is that future treatment regimens will stratify intensity based on molecular, tissue, and CSF analyses, which could increase overall survival, event-free survival, and minimize late effects. Similarly, for our work as neuropsychologists, the development of sensitive markers that correlate with cognitive outcomes could identify those who are at increased risk, which would give us an identification of who we should proactively provide interventions for, and also establish a marker for improvement and effectiveness of these interventions. So things like structural white matter integrity, connectivity versus including DTI and resting state would be great starts for our work collaboratively. Thank you very much.